Welcome to Essential Neuroanatomy Review, Lesion Localization in Neurology. Overview. This is David Lee Gordon, Professor of Neurology. For Essential Neuroanatomy Review, the learning objective is to localize a lesion in the nervous system based on clinical presentation, that is to say, the history and examination. Neuroanatomy is the key to neurologic diagnosis. And there are 10 main areas in the nervous system, 5 in the central nervous system and 5 in the peripheral nervous system. In the central nervous system, there is the cerebral cortex, the cerebral subcortex, the brainstem, cerebellum, and spinal cord. In the peripheral nervous system, there is the nerve root, or in the head, cranial nerve, the nerve plexus, the peripheral nerve, or again in the head, the cranial nerves, and for the motor side, neuromuscular junction. On the sensory side, sensory end organs such as the eye and ear, and the muscle. Lesion localization is an essential early step to diagnosing neurologic disease. In order to properly diagnose patients with neurologic disease, you must first develop a differential diagnosis from the very beginning based on the chief concern, following the SADE or SAID process in order. First, syndrome. Translate the chief concern into possible specific neurologic syndromes. Then anatomy. Localize the potential lesion sites for each syndrome. Diagnoses. After determining the anatomy or the lesion localization, then one can determine the possible medical conditions for each anatomic location. Then etiologies. Once you've figured out the diagnoses possibilities, the differential diagnosis as it were, then you can determine the possible etiologies of each possible diagnosis. If one follows the SADE process in that order on a very consistent basis, you are much more likely to make the correct diagnosis for your patient. The central nervous system consists of 4 main components. Going from rostral, the top, to the caudal bottom, they are the cerebrum, the brainstem, the cerebellum, and the spinal cord. The cerebral consists of 2 components, the cortex and subcortex. The brainstem consists of 3 components, midbrain, pons, and medulla. The word pons in Latin comes from the word for bridge, so it is in between the midbrain and the medulla. The cerebellum is behind, dorsal to the brainstem, and inferior to or caudal to the cerebrum. The spinal cord consists of 4 main regions: cervical, thoracic, lumbar, and sacral. Localizing a lesion in the central nervous system is much like trying to localize a site on a map. Just as on a map, one must know the east-west roads and the north-south roads to figure out where the site is. In the central nervous system, one must know the horizontal wiring and the vertical wiring. The horizontal wiring running from rostral to caudal consists of cognition up in the cortex, cerebral cortex. On the right side of the brain, primarily attention, and the left side, primarily language. The visual pathways and gaze control. Gaze is movement of yoked eye movements. In the brainstem, the horizontal wiring consists of cranial nerves and the horizontal gaze center. In the spinal cord, the horizontal wires are the cervical nerve roots, thoracic nerve roots, lumbar nerve roots, and sacral nerve roots. Please note that the cerebral subcortex has no horizontal wiring. The central nervous system vertical wiring, or north-south roads, are also known as long tracts. They consist of the motor pathways, sensory pathways, and cerebellar pathways, often named by where they start and where they end. The motor pathways descend from rostral to caudal, and they start in the frontal lobe specifically. They're called the corticobulbar tract and corticospinal tract. The cortico means cortex, that's where it starts, although it should be called frontobulbar because it starts specifically in the frontal lobe. All motor pathways start in the frontal lobe. And bulbo refers to brainstem. So they go from the frontal cortex to the brainstem where they innervate the cranial nerves. Corticospinal tract, on the other hand, starts in the frontal cortex and goes to the spinal cord where it innervates nerve roots. It actually descends and the corticobulbar tract crosses over in the brainstem, whereas the corticospinal crosses just caudal to the medulla and then runs ipsilateral to the cranial, to the nerve roots that it innervates in the spinal cord. Note that in the brain, the areas that control the face, arm, and leg are separated in the cortex, but once they leave the cortex and get into the subcortex, the long tracts are bundled together and it's hard to differentiate and have a different lesion causing a problem with the face weakness or body weakness. The sensory pathways are divided into two main categories. Those pathways that carry pain and temperature up to the brain and those that carry vibration and proprioception to the brain. The spinothalamic tract is the tract that carries pain and temperature. In the spinal cord, the pathway that carries vibration and proprioception is called the posterior dorsal columns because they run in the posterior aspect of the spinal cord. Those same pathways, when they get to the brainstem, run in the middle of the brainstem, and so it changes its name to medial meniscus. They'll realize that the medial meniscus is simply a continuation of the posterior dorsal columns. Cerebellar pathways are separate, and in general, the cerebellum controls the ipsilateral body. So those pathways connecting the body through the spinal cord and the cerebellum are ipsilateral. They're on the same side. On this slide, we see the central nervous system, vertical and horizontal wiring depicted together. On this slide, we see the specific clinical findings or symptoms and signs one finds with lesions involving these vertical and horizontal pathways. The vertical findings include hemiparesis, a motor deficit, a hemisensory loss or sensory deficit, and hemiataxia when it involves the cerebellar pathway. The horizontal findings in the cortex can be summarized with the acronym VANG or VANG. They consist of visual field deficits, aphasia if the lesion's on the left especially, neglect if the lesion's on the right especially, and gaze preferences. Recall that there are no horizontal pathways in the subcortex, so there are no horizontal findings in lesions involving the cerebral subcortex. In the brainstem, one involves cranial nerves and the horizontal gaze center, and so the specific findings are double vision or diplopia, gaze palsy, and vertigo. And when lesions involve the spinal cord, the horizontal findings are nerve root lesions known as radiculopathies. When one localizes a lesion that causes weakness, one must consider upper and lower motor neurons. Upper motor neurons are first-order neurons completely in the central nervous system. They start in the frontal lobe. The cell bodies are in the cerebral cortex in the frontal lobe. And they travel via the pyramidal tract, which is the name for the corticobulbar and corticospinal tracts together. And then they synapse on a contralateral part of the brainstem, the lower motor neuron in the brainstem, or the lower motor neuron in the spinal cord. In the spinal cord, that's called the anterior horn. The lower motor neurons are second order neurons. They start in the CNS, but they end in the PNS, in the peripheral nervous system. The cell bodies are in the brainstem and spinal cord. That's the anterior horn in the spinal cord. And they travel in cranial nerves from the brainstem and spinal nerves in the spinal cord. And that's called ventral roots, the motor roots. And they innervate skeletal muscle. One can differentiate lesions involving the upper motor neuron versus the lower motor neuron based on clinical criteria. Folks with upper motor neuron lesions, that is to say, lesions in the brain and spinal cord, have increased tone. The ultimate example of that is spasticity or spastic weakness. They have hyperreflexia. The reflexes are increased. And they have a Babinski sign. When one scratches the bottom of the foot, the toe goes up. That's Babinski sign. On the other hand, the lesions involving the lower motor neurons have flaccid weakness, decreased tone, with decreased or reflex or hyporeflexia, and do not have a Babinski sign. An important thing to remember is that skeletal muscle requires an intact connection to lower motor neurons to be happy, as it were. When the lower motor neuron is not working, not connected properly to skeletal muscle, the muscle shrinks and quivers. Shrinks and quivers. The shrinks is atrophy. The muscle atrophies significantly when you have lower motor neuron lesions, and the muscles twitch. Now, remember that muscles consist of multiple small fibers within a larger fascicle. So the fasciculations is the term for a fascicle twitching. It is visible to the naked eye. You see it on exam. When you have muscle twitches in your body, those are fasciculations. Fibrillations are the small fiber twitches within the fascicle. They are not seen by the naked eye. One can only detect those by an electromyogram or EMG, where a neurologist typically or some other physician puts a needle in the muscle and sees on an oscilloscope some activity. So a big way to differentiate upper and lower motor neuron lesions is the presence of atrophy, fasciculations, and fibrillations. Please realize that this differentiation of how to determine upper versus lower motor neuron was actually first discovered a long time ago, way before we had EMS. And now that we have EMS, we see patients with these lesions very quickly. Prior to that, you would see these patients weeks after their events. It turns out now that we see people as soon as they have a brain injury, such as a stroke or a spinal cord injury, early on, in the first few hours to days, upper motor neuron lesions actually present with decreased tone and reflexes. They become increased only after hours to days. So that is one caveat. This is why in the stroke alerts that we now have for acute stroke therapy, the NIH stroke scale, which is the most common scale used to assess these patients, does not include reflexes, because the reflexes are not of import in the first few hours generally. When assessing a patient's facial weakness, it is very important to start with differentiating between upper motor neuron weakness and lower motor neuron weakness. Let's start by looking at normal facial strength and to know what we're looking for when we do the exam. So at rest, you want to look at a patient's forehead, frontalis muscles, how wide open the eyes are. That's called a pupillal fissure in each eye. The fold between the nose and the lips called the nasolabial fold, and the mouth itself. And when someone smiles normally, the nasolabial folds wrinkle and crease more, and the mouth is upturned. When you say raise your eyebrows, the patient's forehead wrinkles bilaterally, symmetrically. And when you say close your eyes tight, you see, and it's important to actually have them do it tightly, you see that the eyelashes go from mainly up and down to horizontal when they're squishing the eyelids as hard as they can, right? The eyelashes get elevated when they close that orbicularis oculi very closely. When assessing a patient with facial weakness, it is very important to first start by differentiating between upper and lower motor neuron types, because this tells you where the lesion is. The upper motor neuron facial weakness, also known as central facial weakness, has a lesion in the contralateral brain or brainstem above the mid-pons, whereas the lower motor neuron or peripheral facial weakness involves cranial nerve 7 specifically. So very different localizations, and one must stop, don't jump to conclusions, and look carefully and figure out which one it is, upper or lower motor neuron weakness. At rest, the face can look the same in both cases. So there's a flattened nasolabial fold on the side of the weakness, and there's a widened palpebral fissure, although the palpebral fissure is a bit more widened in the lower motor neuron version. You ask the patient to smile, and again, it looks kind of the same. Both cases, the nasolabial fold is especially now more prominently not working on one side, and the palpebral fissure remains widened. The close your eyes tightly is a bit different. In the upper motor neuron, usually the eye closure weakness is mild. And so even though they can't close the eye as tightly on the affected side, the eye is still mainly closed, and there's little danger of drying out the cornea from not being able to blink. Whereas in the lower motor neuron version, they usually can't close their eye at all, and there is this danger of drying out the cornea. That's why a major part of the treatment for these peripheral 7 lesions is lubrication of the eye. The biggest differentiating factor between upper and lower motor neuron lesions for the facial weakness is the forehead. When you say raise your eyebrows, the upper motor neuron, strangely enough, can elevate both sides equally. The upper motor neuron lesions do not affect the frontalis at all, whereas the lower motor neuron weakness causes ipsilateral forehead weakness, frontalis weakness, and they cannot wrinkle their forehead on that side. They cannot elevate their brow on that side. Bladder dysfunction can also be separated into upper and lower motor neuron versions. The term neurogenic bladder can be used broadly to mean any neurologic problem leading to bladder dysfunction. But in this presentation, we're going to limit the term to specifically lesions that cause parasympathetic dysfunction with detrusor sphincter dyssynergia. The detrusor is the bladder muscle, and when we say sphincter, we're referring to the internal urethral sphincter. And dyssynergia means not working together. Synergia, working together. Dys, D-Y-S, not, or abnormal. So people with either upper motor neuron or lower motor neuron neurogenic bladders have a condition in which the bladder muscle is not working well with the internal urethral sphincter. Upper motor neuron lesions start in the pons and go down to the sacral spinal cord because the parasympathetics start in the pons. You cannot get an upper motor neuron neurogenic bladder from the cerebral cortex. That's not possible. You can get incontinence from there, but not upper motor neuron neurogenic bladder. We'll talk about that in a second. Because the vast majority of the wiring that involves the bladder in the upper motor neuron is in the spinal cord. We specifically, when people have upper motor neuron neurogenic bladders, the lesion's almost always in the cervical or thoracic spinal cord. A myelopathy refers to a spinal cord injury. Myelo is spinal cord pathy disease. So a cervical or thoracic myelopathy is by far the most common cause of upper motor neuron neurogenic bladder. And this bladder is small and spastic or hypertonic. The symptoms would be frequency, because the bladder can't get big, so you have to go all the time. Urgency, because you always feel like you have to go. Hesitancy, because you can't go because the sphincters close when you try to contract. And small volumes, because you can't get much out. So frequency, urgency, hesitancy, small volumes. Those are the 4 symptoms of upper motor neuron neurogenic bladder. Lower motor neuron neurogenic bladder refers to lesions involving the sacral nerve roots and out to the peripheral nerves that go to the spinal, to the bladder, specifically in S2 through 4, sacral 2 through sacral 4 nerve roots. The most common cause of this will be spinal stenosis, which is osteoarthritis in the sacrum causing compression of these nerve roots, right? This can also be caused by chronic meningitis and picking off nerve roots, myeloneuropathy multiplex, or other causes. The lower motor neuron neurogenic bladder is large and flaccid, i.e. hypotonic. And the symptoms are overflow incontinence and dribbling. Overflow incontinence and dribbling. Those are very different kinds of incontinence. And so it's really important to differentiate those when seeing a patient with incontinence. Now, there's a third kind of neurologic bladder dysfunction that is not sometimes included as a neurogenic bladder, sometimes not, and that's bifrontal dysfunction. So bifrontal dysfunction occurs in babies. So remember that babies myelinate from the back to the front. That's why, what's in the back? The occipital lobes. That's why they see early on. And in front of that's the parietal lobe. So they sense, they can feel pain and stuff and things like that. The last thing to myelinate is the frontal lobe. That's why babies are incontinent early on, because they cannot control the voluntary control of their bladder and bowel. And so what is another possible cause of bifrontal dysfunction? Well, trauma to the frontal lobes, bilateral frontal strokes, dementia and other dementing diseases like Alzheimer's, etc. So bifrontal dysfunction leads to a different kind of incontinence where the volumes are normal. So the patient may have a bit of an urgency because they say, oh, wait a minute, I have to go, and then they go. But unlike the upper motor neuron bladder, the bladder dysfunction from bifrontal disease leads to a normal volume. Normal volume. It's just like a baby. Baby does not have a neurologic problem. They just don't have myelin in the frontal lobes, and they go a large volume. And this is what happens to folks with dementias. So this is a simple overview of brain anatomy on a coronal view. And we have 4 main components: the cerebral cortex, the area under it, cleverly named the cerebral subcortex, the brainstem, which is that connector between the subcortex and the spinal cord, and the cerebellum, which is behind the brainstem and beneath the cerebral cortex. The cerebral cortex is the computer center of the brain. It consists only of gray matter, the neuron bodies, cell bodies themselves, the computer center, where we think and do, etc., feel, etc. In general, the front of the cortex is motor, and the back is sensory. In general, the left pertains to language, and the right has control of attention. And there are 5 zones: the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, and the insula. The cerebral subcortex consists of 2 things: deep white matter, which consists of wires, basically, going up and down, and 2 gray matter balls, 2 sets of gray matter balls. The motor modifier balls, which are the basal ganglia, and the sensory consciousness relay station balls, called the thalami, thalamus on each side. The brainstem, beneath the subcortex, is the funnel or connector between the cerebrum and spinal cord, and it has wires to the ipsilateral, usually ipsilateral face and head, called cranial nerves. It also has primitive centers, which we'll talk about, things like the breathing center and the consciousness center and the nausea vomiting center, etc. The cerebellum is the coordination center. It makes skeletal muscle agonists and antagonists communicate with each other so that you can have coordinated movements. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.